guys, and welcome back. In today's video, we're going to talk about 2 reasons why you might have bloating and diarrhea from the ingestion of oral fat: bile acid malabsorption and fat malabsorption. Stay tuned to learn which one you might have, differentiate between the symptoms, and most importantly, what you could do about it. Let's start off by talking about what each of these things is and what the symptom is going to look like for each of these. Again, as the name of this video implies, you can get diarrhea and bloating from either of these, but the cause and what is going on is going to be slightly different. So let's start with just run-of-the-mill fat malabsorption. What you're looking at for fat malabsorption is going to be difficulty ingesting and absorbing your fat. Now, normally we ingest fat, and then we have different enzymes from the pancreas, the liver, the gallbladder, and the microbes, and the brush border that are going to help you break down that fat into very small chunks and then absorb it so that it gets in through the cells of the lining of the intestines and into your bloodstream. So if you have fat malabsorption, the potential culprits, the potential tissues that are involved in that and may need some attention include the pancreas, which I'm going to try to highlight here, the pancreas, the gallbladder, the liver, or perhaps the brush border or some portion of the small bowel, because we do have enzymes that are produced directly in the small bowel. Maybe the microbiome is involved as well, but I think that's a little bit less clear as opposed to bile acid malabsorption, which I think is a more strong microbially induced link. But in the case of fat malabsorption, you could have that because of pancreatic insufficiency. You could have that because you got your gallbladder taken out. Granted, that is also common with BAM, or bile acid malabsorption. It could be that your liver is not producing enough bile. It could be that your gallbladder is not squirting out that bile and giving you that nice oomph of digestive juices when you need it most during mealtime. Or, like I said, it could be because you don't have a lot of brush border enzymes, the enzymes that are made right at the level of the small intestinal surface that are supposed to further break down your fat. So potential tissue targets, I'm just going to shorthand everything. So it could be liver, gallbladder, pancreas, or brush border. Those would be the 4 main targets that I would think of as far as like structural or anatomical reasons why you would have fat malabsorption. On the flip side, when you think of bile acid malabsorption, that pretty much rules out the pancreas because the pancreas is not involved in the process of making and concentrating bile. Again, bile acid malabsorption is common amongst people who have had their gallbladders removed. I think I've seen some studies that suggest about 2/3 prevalence amongst people who get their gallbladder removed and then have diarrhea after that. So if that sounds like your story, then I would highly suspect something like bile acid malabsorption. But it could also be due to an inefficiency in the recycling. So normally you make bile in the liver, it's concentrated and stored in the gallbladder, and then it's released in these nice powerful squirts of good concentrated bile during mealtime. It gets dumped into the first part of the small intestine, the duodenum, and then it makes its way through the small intestines, and then most importantly, the location that is most relevant to this conversation ends up being the distal ileum, which is the very, very, very last part of the small intestine, right before it connects with the colon or the cecum. And that is where the vast majority of these bile acids are going to be absorbed into the bloodstream and recirculated and put back into use in the liver and the gallbladder. So it takes a lot of stress off the liver and gallbladder because you don't need to be constantly making a lot of bile acids. You can actually recycle about 95% of those. So if you think from this perspective, .95% is going to be reabsorbed and recycled, given back to the liver, and then bada bing, bada boom, off you go. So the 2 anatomical structures that I would say are the most relevant for the conversation of bile acid malabsorption, number 1 is going to be that last part of the ileum, that furthest part of the small intestine. And then maybe as a secondary runner-up, we could think about gallbladder or liver. And likewise, if you look at some of the conditions that are associated with bile acid malabsorption, it can range from conditions that oftentimes affect the latter part of the small bowel, most notably SIBO, Crohn's, and celiac disease, but also in people who have had their gallbladders removed or have liver disease, something like cirrhosis or NAFLD. Those can also cause bile acid malabsorption. Again, maybe in the cases of NAFLD and gallbladder issues, maybe it's less about the absorption from the latter part of the intestine. Maybe it's that the gallbladder and the liver cannot process those recycled bile acids. So we've got, as far as therapeutic targets, we could make an argument for, I'll just put DI for distal ileum, gallbladder, and liver. So that kind of helps narrow down a little bit. So in the case of bile acid malabsorption, this person would probably not respond to digestive enzymes. They might respond to something like a bile binder, like charcoal, but not necessarily additional enzymes. Versus somebody over here who has fat malabsorption because, say, they have some pancreatic insufficiency, that person could take pancreatic enzymes, digestive enzymes, or brush border enzymes, and that could be curative or close to curative for the symptoms they're experiencing. So it matters which one of these you have and trying to understand how to narrow down what you're looking at. Is it because of pancreatic insufficiency, gallbladder issues, liver issues, brush border / leaky gut issues? Is it microbial? Because again, keep in mind, we have a lot of microbes in the small intestine and the colon. And if you have small intestinal bacterial overgrowth, that could be the root cause of bile acid malabsorption or fat malabsorption, in which case you need to treat the microbial environment and repair that tissue and get the ileum to a point where it's acting how it should and it's doing its daily functions. Of note also, I think that it's really interesting that the location of this is the latter part of the ileum, which is going to be affected tremendously by SIBO, and there is a post-infectious variety of bile acid malabsorption. So if you got food poisoning with like Campylobacter or Shigella or one of those nasty, nasty pathogens that you might see on the first page of a GI map, for example, those pathogens can damage or inhibit motility or the lining of the distal ileum, and then that can produce bile acid malabsorption, and it's from a post-infectious model. And of course we know, or those of you who have been on my channel for a while know, that food poisoning can trigger post-infectious IBS, which is really a subtype of SIBO. Think of it almost like an autoimmune motility problem that will cause SIBO for about 90% of people who get that. So if you want more videos, I have a lot more on this channel, or I could do some more in the future if you want fresh content on that topic. But post-infectious IBS or post-infectious SIBO probably is a big driving factor for anybody who has post-infectious bile acid malabsorption. But let's back up a minute and talk a little bit more about the signs and symptoms of both of these, because there are some differentiating factors that you might consider and help you rule in and rule out one or the other. So in the case of fat malabsorption, again, maybe not bile acid malabsorption involved in this case, but with simple run-of-the-mill fat malabsorption from a liver, gallbladder, pancreatic, or brush border standpoint, you'll have diarrhea. Bloating is fairly common, not universal, but fairly common. Usually patients with this will describe that their stools look fatty or greasy, like they have a sheen to them on the top of the toilet water. I had one patient actually describe her stools as looking foamy. So if you see like a foam to your stools, that could also be the case. And usually, not always, but very often, you will notice that the stools are very pale. Instead of that nice chocolatey brown Tootsie Roll color, you might expect something between that and khaki color. So it's a pale brown or like a tan color. As opposed to bile acid malabsorption, diarrhea, absolutely. Bloating, fairly common amongst these folks also. But rather than just being a paler color brown, oftentimes people will report that they have a little bit of a yellowish or a greenish tinge to the stool color. Again, it might be like a yellowish brown or a greenish brown, but usually there's some sort of color change to the stool as well. And that's because these bile acids have a yellowish greenish cast to them. So if you're malabsorbing them and more of these bile acids are making it into the colon and then into the stool, you're going to expect to see more color from the bile acids themselves because you're pooping them out, you're excreting them, instead of reabsorbing them as you normally would. So yellow or green stools, I would think a little bit more along the lines of bile acid malabsorption. Pale or really fatty, shiny, or foamy stools without that coloration change, I might think along the lines of run-of-the-mill fat malabsorption, and that opens the conversation for pancreas and brush border enzyme deficiency in addition to the gallbladder and the liver. Now, once you find out that you have one of these things, the question becomes, how do you treat it? And this is very important because both of these are relatively common. I wasn't able to pull up statistics for run-of-the-mill fat malabsorption, but for bile acid malabsorption, it is said to affect about 1/3 of people who have IBS diarrhea, IBSD, about half of people who have what's called functional diarrhea, or like diarrhea that doesn't meet Rome criteria for IBS, just diarrhea of an unknown cause, about half of people with functional diarrhea, about 1/3 of people who have microscopic colitis, and about 2/3 of people, as I mentioned, who have had their gallbladder removed and then started having diarrhea after their gallbladder was removed. So if you think about how prevalent IBS is, how prevalent it is for people to have their gallbladder removed, this is a pretty common problem, bile acid malabsorption. And I would guess that fat malabsorption is more common than that, but I couldn't find the stats for that. Now, as far as treating it, again, if you could try to understand where the deficiency is coming from or where the problem is coming from. So for example, if you have any symptoms of pancreatitis, or if you have any known pancreatic insufficiency issue, say for example, you got some stool testing done for fecal elastase, or you looked at digestive enzyme output on something like Doctor's Data or a GI map stool test or a LabCorp test. If you have enzyme insufficiency via elastase and you have some of these symptoms, then I would start with a pancreatic enzyme. If it's low enough, below about 200, you might actually consider doing a prescription-based pancreatic enzyme supplement. But if it's somewhere, subclinical, like in the 200 or 300 range, or if it's in the high 100s and you really don't want to do a medication, there are a lot of good digestive enzyme products out on the market. One of my favorites is called Enzymix Pro. It's from a company called Apex Energetics. I'm going to link in the description somewhere down below, and I'll try to pin it to the top of the comments. Some links where you can get Apex Energetics products without a practitioner. But Enzymix Pro I like because it has a little bit of betaine HCl, a little bit of pancreatic enzymes, and a little bit of brush border enzymes. So it's kind of like the jack of all trades enzyme supplement, but it does a really nice job. So I would start, for example, with brush border enzymes or pancreatic enzymes. There are other good pancreatic enzymes from companies like Pure Encapsulations, Designs for Health, Vital Nutrients, but I tend to like that Apex product because it does have some brush border enzymes and some HCl in it as well. If you think that you have more of a gallbladder issue, like say you have a history of gallstones or gall sludge, or you have a history of non-alcoholic fatty liver disease, NAFLD, or cirrhosis, and you think it's more of like a liver and gallbladder thing, then I would work on that angle. So you might consider things like ox bile. If you start on ox bile and you have fat malabsorption, that could be corrective for the problem. If you take a supplement with ox bile and you have bile acid malabsorption, it's going to make the problem worse. Because remember, the problem is not the production of bile acid for this person. It's that you actually have too many bile acids making it to the colon because they're not getting reabsorbed and put back into the circulation. So taking bile for this person will most likely make them worse. For this person, if it is a bile-based deficiency, like a liver or gallbladder problem, it could make them feel a heck of a lot better. So that would also be in the cards. I would also consider herbs that can thin or promote the flow of bile. Things like beet, fringe tree, barberry. There's a lot of different herbs. Heck, even humble dandelion root. There's a lot of herbal medicines and a lot of nutritional considerations. Everything, again, from beets, bone broth, that can help with the flow of bile or the function of the liver and the gallbladder. So those, I think, would be perfectly reasonable for people in this situation. If, on the other hand, you are able to confirm bile acid malabsorption, or if you think that that is highly likely to be your problem, as I said, bile-based supplements like ox bile probably are going to make you feel worse, or it's going to exacerbate some of these symptoms. You might do well with a bile acid sequestrant. So for example, there's a prescription called cholestyramine that does this. I'm not a prescriber, so it's not really my place to tell you much about that, but that can be helpful. I've referred some patients out to get that drug. Or you could do things like bile acid sequestrants of a natural variety, like charcoal or bentonite clay. some of the supplemental over-the-counter binders can also be helpful for that as well. Possibly even bismuth could be useful, although I don't have a lot of experience with that. I tend to use charcoal more so. But binders could be a really useful thing here. The other thing that I find really fascinating, and this is very new, so I don't have a lot to tell you about it, but just food for thought. It seems like the receptors that aid in this recirculation of bile acids have something to do with receptors for what's called GLP-1, glucagon-like peptide 1, and that is something that's secreted in the last part of the small intestine and beginning of the colon, so location makes sense. GLP-1 is secreted in response to food intake, and it helps your pancreas produce insulin at the right time in response to food. And that GLP-1 molecule is very much associated with proper glucose control. It's been researched quite a bit now for diabetes and even for obesity, but it seems like there's some link with the function of the distal ileum and bile acid recycling and this GLP-1 thing. And I know because as I was reading some articles and finding some references for you guys to put in the description, I found some interesting articles that were starting to look at the use of a drug called Victoza, or I think it's lorindotide or something like that. I don't know, I'll put it in the description. But this drug that is a GLP-1 receptor agonist, so it activates that receptor. That drug has been shown to treat bile acid malabsorption in some small human studies. So it makes you wonder if part of this problem comes about because of insulin resistance or blood sugar control, or if there's some mechanism with GLP-1, because the drug that is an agonist for that receptor or activates that receptor seems to treat the problem. So I think it harkens back to blood sugar control being really, really crucial for gut healing and gut function. And that is something I do have on the schedule for the fall to do videos on. If you really want more of those GLP-1 and blood sugar control and like gut function videos, pop a comment down in the comment box, and then that'll let me know that I need to move that up in my recording schedule, because right now it's probably not going to hit until late fall, early winter that I have that on the schedule for, but I will bump it up if a lot of you comment down below that you want those videos sooner. But it seems like blood sugar control is particularly important for this recycling of bile acids. Now again, I'm not a prescriber. I don't have any experience whatsoever with this drug. I only know of it because I've studied blood sugar regulation and functional medicine so much that I already knew about GLP-1, and I was just a little bit familiar with these drugs, and I found it really fascinating that they seem to do a pretty good job at treating potentially the root cause of bile acid malabsorption. Now, granted, you don't want to be stuck on a prescription drug forever and ever. So in the case of blood sugar control, there are natural substances that can promote GLP-1 activity. So again, if you want me to do videos on that a little sooner than later, just let me know and I can move that up in my recording schedule. But there are natural things that can do that. They might not be quite as powerful as the prescription drug, but I think that they are going to be a bit safer and better tolerated by the majority of people, and I would be more willing to take a supplement than a medication personally. And before I let you go, there's one more thought that I wanted to share about bile acid malabsorption in particular, and that is, yes, you could do bile sequestering agents like charcoal and clay and cholestyramine, but it gets just a teeny bit more complex than that. So I wanted to share this thought with you as well. As I said, normally the liver produces bile. It is concentrated about 10-fold in the gallbladder, and the gallbladder hangs on to that bile until you really need it and you have a fatty meal, and then it gives you a nice powerful squirt of the good stuff. That is dumped into the first part of the small intestine. It emulsifies the fat and helps you absorb the fat all the way through the small intestine, and then those bile acids should be absorbed and kicked back up to the liver for use again in the latter part of the small intestine. So bile acids are really doing their thing in the small intestine. They shouldn't be getting to the colon in an abundance, and they shouldn't be refluxing back up into the stomach, although that can happen as well. But if you think about, again, the case of SIBO and how much messing up the microbiome and messing up the environment in the small intestine could lead to dysregulated bile acid metabolism and vice versa, it's a two-way street. I think the SIBO conversation becomes incredibly important. And again, there's other causes. Crohn's, celiac disease, pancreatitis, anything that will affect the small intestine has the potential to cause this. Also, things like anatomical variants like blind loops, radiation or chemotherapy could potentially be damaging for the small bowel as well. But one of the things that happens when you get your gallbladder taken out is, again, normally you have this constant drip of very dilute bile coming down out of the liver, and then your gallbladder concentrates that. Well, if you get rid of your gallbladder, for whatever reason, if you had gallstones or emergency surgery, if you no longer have a gallbladder, you don't have that reservoir to concentrate the bile. So you get in this weird kind of situation where you can have a bile deficiency at mealtime, right? Because you don't have that sac, that gallbladder, to give you the nice powerful squirt of the good stuff. So it's kind of like you have a deficiency in bile around mealtime, and you have an excess of bile outside of mealtime, because again, you have that constant drip. So if you're going to use bile sequestering agents, you want to take those away from meals, whether that be charcoal, clay, cholestyramine, whatever it is, you want to take that away from meals. But after you get that on board and you see how much that is helping you, you might actually consider a teeny tiny dose of actual bile. So again, this would be like ox bile, for example. But you might be able to do a little bit of ox bile with meals if you are also mopping up the excess bile outside of meals. So it's weird, like you get into this weird kind of, I don't want to call it a roller coaster, but like this weird ebb and flow where one moment of the day you're promoting extra bile, or you're trying to get your hands on extra bile, and then you want to mop it up, and then you want more, and then you want less, and you want more, and you want less. But that strategy of giving the person more bile at mealtime and trying to mop up excess bile outside of mealtime has proven to be really helpful for a lot of my patients who have either of these issues. Again, whether it be fat malabsorption or bile malabsorption, I usually think of the strategy of more and less, more and less. I think of that more for bile acid malabsorption, but feel free to play with that as well. It's relatively easy and relatively cheap to get your hands on some charcoal or some clay, and then maybe get you a bile type supplement like an ox bile supplement. I would just say be cautious to get the bile sequestering agents on board first, and then layer in the ox bile a little bit at a time. Don't go in guns a-blazing with a high dose right out the bat, because again, if you're malabsorbing, it could make these symptoms a bit worse in the beginning. So you really want to layer in that bile acid binding or the blood sugar work first, and then you might consider something like ox bile. Hey guys, if you like this video, be sure to subscribe, ring the bell, click the like button, and leave a comment down below with the videos that you would like to see me do next. Doing all of those really helps support the channel and support my efforts in making as many videos as possible for you guys. Thanks so much, and I'll see you in the next video.